I can do a quick intro.
We're rolling.
Awesome. Welcome everyone to today's mega quiz series. So I think we've gone through quite a few topics in the past. Today we're going to be focusing on neuro and MSK and a bit of room as well in the MSK section. But hopefully you find these topics high yield and they revise what you've learned throughout the year. Again, if you have any questions throughout the way, feel free to stop us and drop your questions in the comments or even just shout out on the Zoom, whatever you're comfortable with. But without further ado, we'll get started. Awesome. So our first question is up there on the screen. Wait, do we normally say the questions out loud, James? Or do we just like leave them on the screen?
I think for the sake of time, it's easier to just explain the basics of the question if there's anything you need to clarify and just let people think about it.
Awesome. So basically we've got a lady with joint pain, rash on her face, discolored fingers. Have a look at the question and what do we think we should prescribe here? And let us know in the chat. You can either direct message me or one of the others or just put it up for the whole group to see. And once we get a couple of answers coming in, awesome. We've got some answers coming in. Oh, conflicting answers. Nice. I'll give it a couple more seconds. Have you guys got any answers on your chat as well? Nope. Okay, I've had two come through so far. Okay. All right, let's move on to the answers now. So having a look at the question, the first thing is to figure out what this person has. And so they've got joint pains or arthralgia. And again, it's important to consider, the age, gender as well, because some conditions are more prevalent in some genders, and the symptoms, right? So the terms here are pretty simple, but what you're looking at is a butterfly rash, which is sparing the nasolabial fold, which is the same thing as the smile lines. And the discolored fingers, it's a bit tricky figuring out what that is because you might not have seen it described that way, but it's describing Raynaud's phenomenon, right? And that's why it's worse in the cold and during stresses. And so this all sort of correlates and points towards an SLE picture with the butterfly rash and all those other symptoms. And given that, the sort of cornerstone of treatment is actually going to be hydroxychloroquine, otherwise known as Plaquenil. So even though all the other answers there are sort of, I guess, immune modifying agents, the most effective one here for SLE is going to be hydroxychloroquine, which you're going to be prescribing here. Yep, so that's that question. Any concerns about that? Feel free to let us know in the chat. I think some people are talking about prednisolone or AIDS steroid. That's also an option, but in the case of SLE, if you look at ETG as well, the sort of cornerstone of treatment is going to be hydroxychloroquine. Awesome. Let's move on to the next one. All right, so we've got a 40-year-old patient, mechanical heart valve, back pain, fever, skin boil excision 4 weeks ago. There's now got a new murmur. What does he have? All right, I'm not getting any answers yet. Come on, guys. What do we think's going on here? How can the back pain be sewn in with everything else here? Okay, we've got a couple of answers coming through. I'm liking it. Different answers coming through. Okay, okay. So some C's, some E's. Awesome. I think we'll talk about the answer now. So the answer here is, in fact, like a lot of people have said, it's bacterial osteomyelitis. Now, how does that even make sense? Well, if we look at over here, the sort of initiating event seems to be this skin boil excision 4 weeks ago, right? So that seems to have triggered everything off. So we've had the skin boil excision, most likely some sort of Staph aureus picture there. So the excision might have caused the Staph aureus to leak into the venous system, travel up to the heart, and in this case, form vegetation on the aortic valve. The reason it's the aortic valve is, and you can have a look as well on AMBOSS or other sources, but the most commonly affected valve in an acute sort of regurg picture of an infective endocarditis is the aortic valve. So you get an aortic regurg picture here, and that's why you have that decrescendo diastolic murmur at the left lower sternal edge. And if you have agitations on the aortic valve, they can sort of flick off anterior systemic circulation. and infect tissue downstream, right? And in this case, we see back pain, and the reason is that it's probably entering either some bony structures or some muscular structures in the back and causing the pain there. And hence the fever as well fits that picture of sort of sepsis as well. So that's why the answer here is bacterial osteomyelitis. Some people, I think, said spinal metastases. We don't really see any of the classic features of like cancer, where we have systemic symptoms, and besides the fever, you don't see sort of like weight loss, and you don't see anything else pointing that direction. So that's why it's not going to be spinal metastases, but it's in fact going to be bacterial osteomyelitis. I hope that all makes sense. So we'll move on to the next one. So here's a bit of a revision of lumbar punctures for everyone. So 45-year-old woman, loss of vision in her right eye, motor neuron weakness, and a bunch of other signs. We've done a lumbar puncture, we've got these findings. What do we prescribe next? And again, once we put these slides up, you can have a look under the speaker notes and have a look and see explanations for each of these questions as well, so it all makes sense to you later. Okay. Awesome. We had some answers coming through. Amazing. Everyone's choosing B. Correct. So in this case, we do have, as someone has mentioned, a picture of MS. What's going on here is you see optic neuritis, right, which is the loss of vision in the right eye. You see motor neuron weakness, hyperreflexia, hypertonicity, all again correlating and pointing towards that multiple sclerosis picture. And the lumbar puncture is sort of confirmatory as well, because the major feature we see on lumbar puncture, which really points us towards MS, is the IgG oligoclonal bands. Very, very high yield, important to keep in mind for lumbar punctures is the IgG oligoclonal bands. So because she has MS and it's sort of a acute flare because she's got that loss of vision in her right eye, we're going to prescribe, as ETG suggests, high dose steroids. So it's going to be B and not the other answer options there. Great job, guys. We'll go on to the next question. So 20-year-old student in the ED, headache, neck stiffness, fever, tachycardia, photophobia, non-blanching rash, and some pain when extending their knees. What? And bonus questions, whoever can name that sign as well in the chat. And what to prescribe. Awesome. I've got some people correctly saying Koenig sign. Okay, we've got a couple of answers coming through. Most people have said B. Yep, correct. So in this case, we have a classic picture of meningitis. We've got the meningisms and headache, neck stiffness, and so on and so forth, photophobia, no nausea and vomiting, but everything else sort of points towards meningism anyways. We've got the fever, we've got tachycardia there as well. And the rash is suggestive, it's non-blanching, suggestive of meningococcal disease. And the sign here, as someone mentioned, is Koenig sign. So when you flex the hips to 90 degrees and you try to extend their knees, you get some pain elicited. And that's because stretching the nerves, which are already being affected by the infection. So the answer here is ceftriaxone and dexamethasone. You won't remove the dexamethasone just yet in this case because we haven't confirmed, I guess, with bacterial cultures if it is Neisseria meningitis. So you're just going to keep the dexamethasone on for now. But if your faculty says otherwise, if, for example, they say like the rash is very suggestive of Neisseria and therefore you remove dexamethasone, then go ahead with A. Because in reality, if you do confirm it's Neisseria, you would actually remove dexamethasone because there's no evidence, according to ETG, that dexamethasone actually adds any particular benefit. But it doesn't actually harm the patient either. So in this case, we've gone ahead and put B as our correct answer for this question. Awesome. So the answer there is B. So again, next question, 7-year-old woman, past history of breast cancer, recent onset thoracic back pain. X-ray reveals wedging of the vertebral bodies. DEXA scan with a T-score of -2.8, and she's already on some supplements. So what should we give her next? Awesome. Some answers coming through. Yep. So everyone seems to be saying A, and you'll be correct. So basically, the picture we have here is one of osteoporosis. And again, the sort of clinching factor here is the T-score of less than -2, or I think -2.5 in some textbooks. So that points towards osteoporosis. And because of that, and the fact that calcium and vitamin D haven't worked for this person, we're going to provide bisphosphonates as our first line treatment. Everything else is irrelevant. The cholecalciferol, just for curiosity, is just vitamin D. So that's not going to help because she's already on that. And so in this case, A is the correct answer. So good job, everyone. All right, 55-year-old diabetic, dull left shoulder pain and stiffness, worse at night, and global restriction of movements, both active and passive. What's going on here? Bit of MSK revision. Got some answers coming through. A lot of question marks coming through as well. It is a bit of a confusing question because I don't think it's explicitly taught um, on your matrix, but I have seen it in a couple of places in practice questions from your exams. But I've got a couple of C's and E's coming through, a lot of E's mainly. So the answer is in fact E, so adhesive capsulitis, also known as frozen shoulder. So the picture here is dull left shoulder pain and stiffness, and it's worse at night. So adhesive capsulitis is basically an inflammatory condition where you get inflammation and fibrosis of the joint capsule, and that sort of makes it hard for you to move the shoulder joint. And that restriction is global. So it occurs in both active and passive movements because of the fibrosis. And it occurs in all directions, right? Irrespective of internal and external rotation. And that's the reason why you go with the answer as being E. The other ones that probably produce more focal symptoms. So for example, supraspinatus tendonitis would maybe only produce pain on external rotation, and it would also be pain on sort of, I guess, resisted movements as well when you're doing external rotation. So someone in the chat has asked about that. That's the reason why it's not going to be A. And yep, so for that reason, we're going to put E as the answer and move on. A 20-year-old woman increasing painless proximal muscle weakness over 4 months. Difficulty rising from a chair, combing her hair, positive ANA, and a raised CK. What is the condition here? All right, a couple of answers coming through. Getting a bit of a split between A and B. A lot of A's. So the answer actually in this case, and the reason it's not going to be A, is that the positive ANA, and especially the raised CK, points you towards some sort of autoimmune process, and the raised CK implies that it's damaging muscle tissue. So that's why it's not going to be polymyalgia rheumatica. It's instead going to be polymyositis, and the raised CK in particular points towards that. The polymyalgia rheumatica, the age group tends to be a bit older. You do get similar symptoms, but you don't get the raised CK in polymyalgia rheumatica. That's the major difference between both of them. That's why the answer here is going to be B. All right. Now this question's a bit of a revision of some concepts from year 1 and year 2. But have a go at this one. So we've got a 30-year-old man. He's had a car accident with a back injury. He's unable to move his right leg, and he has a bunch of other neurological findings. What do we think is going on here? If someone can put in the chat the eponymous name for this condition as well. Okay, getting a lot of D's. Yep, amazing. Brown-Séquard. So the answer is D. So what's going on here is we have a picture of spinal injury, and the car accident and the subsequent back injury points towards some sort of spinal injury. And the subsequent neurological findings also indicate that. So normally when you have a spinal injury, you acutely have spinal shock, right? So everything below that level sort of stops working. But then in some cases, you can develop hemisection of the spinal cord where essentially one side of the spinal cord seems to stop working. And if you click again on the image, Jane, it might show a little diagram there. So what we've got happening here is Brown-Séquard syndrome, and I'll try and briefly explain what's going on. The main thing to understand, the tricky thing is what's going on with the spinal thalamic tract. Everything else sort of makes sense. The only thing that doesn't make sense is the spinal thalamic tract. So if we assume that the right side of the cord is damaged, it explains why his right leg is unable to move, but his left leg is fine. And also why he has upgoing plantars, so upper motor neuron signs on his right leg, but his left leg is normal, right? Downgoing. But the main difference that we see is with the pain and temperature in the right and left leg, and also the vibration sense in the right and left leg. If you look at pain and temperature, it's preserved in the right leg, but lost in the left leg. The reason being the spinal thalamic tract is a bit special because it actually decussates or crosses over in the spinal cord at a higher level. So what's happening here is that if you damage the right side of the spinal cord, sure, you'll damage the fibers running through that area, but the fibers from the spinal thalamic tract that run through that area actually come from the opposite side, which is why below that level, on the opposite side, so the contralateral side, the left leg, you're actually going to lose pain and temperature in the spinal thalamic tract, but it's going to be preserved on the right side because that crosses over and sort of bypasses that injury in a sense. And you can have a look at specifically what areas are affected and unaffected in that diagram below. I've tried to point them out, but that's basically all you have to know to understand what's happening in this question. So the answer is D. On to the next question. Again, another lumbar puncture. So 24-year-old man, low-grade fever, headache, photophobia. What do we prescribe? Have a look at the LP. Let me know what he has and what you would give. And I'm going through it fairly quickly, so if you do have any questions, feel free to put them in the chat as well. Amazing. Okay, so we've got a couple of answers coming through. So some D's and C's, mainly D's. The answer is, yeah, correct. It's going to be D. So in this case, you actually wouldn't give antibiotics at all because we do see a meningism picture here, right? The fever, the headache, the photophobia. We all think it's meningitis. But if we have a look at the lumbar puncture, it's clear in appearance. It's got high protein, so something's going on there. But also importantly, the glucose is normal, right? So it's not really a bacterial picture where you'd have bacteria consuming the glucose and it being low. And the gram stain is negative, so we're not really growing much there. And the white cell count is raised with predominantly lymphocytes, again, pointing towards more of a viral picture where lymphocytes are involved. So because we have a viral meningitis, our primary mode of treatment is pretty much no treatment or supportive treatment. So we're going to be hydrating them, supporting them, and maybe giving some analgesia. So in this case, paracetamol is fine, but antibiotics are not. They're not going to help at all. So the answer here is going to be D, like everyone has said. So D. Next question.
And just to add on to that, that was a great explanation, Janu. I just got a few people who were confused with the gram stain. When it says negative, it doesn't mean gram negative. It means that there was no staining whatsoever. So that might have been a little bit confusing, but the rest of the picture should match with what Janu was saying for a viral meningitis.
Yep, exactly. So it's like negative for growing anything as opposed to negative for the gram stain. Yeah. Awesome. Here's some imaging from a 7-year-old who's fallen on her outstretched right hand with immediate pain and swelling. and a wrist x-ray done. What's going on here? Very good. Amazing. So we've got mainly D coming through as the answer, or only D coming through as the answer, which is correct. So what we have here is a Colles fracture. And particularly, I think when you have an outstretched hand where the hand is dorsally angulated, so sort of like that, and then you fall onto it, you get the you get that radial fracture, but the distal fragment is going to be pushed up dorsally as well. So that's why it's called a dinner fork deformity, because of the shape that ends up happening, and it's called a Colles fracture. Whereas if you fell on your hand where it was, I guess, pointed the other way, you'd get a Smith's fracture, where the distal fragment actually goes inwards, and that's more dangerous because it can actually damage structures under it. But yep, we have a Colles fracture here, and I think imaging is very important to keep in mind, because faculty seems to be sort of moving away from asking the typical MCQ questions and putting a lot more imaging into their questions. So have a look at some images on Radiopedia, whatever resource you can, to try and really understand, not just from MSK and Neuro, but also from RESP, and especially like RESP and GIT. There's a lot of imaging there. So see if you can revise that in preparation for your exams. So that's going to be D. Next question.
And just to help you remember the Colles fracture, you can just remember it's all to do with D. It's like a dorsally displaced distal fracture, and it's a dinner fork deformity. So it all kind of makes sense with the 4Ds. So the next question looks like it's mine. This one is a bit of a long one. Just have a read. We're bringing it back to a bit of neuro as well. And headaches, head pain, very, very important sort of presenting complaint to have a good list of differentials for. So you've got a 28-year-old with a severe headache, throbbing pain on one side of the head associated with nausea and vomiting. Similar episodes have happened in the past, lasting several hours to a day, as well as visual disturbances. A physical exam is otherwise normal. So what do we think this patient has? Now, I'm already getting a lot of answers, which is great. The answer here is C, 100%. So we've got a typical picture of a migraine. As you would know, with a cluster headache, you would have that kind of rhinorrhea and that sort of picture of watery eyes and that sort of thing. And it's quite a lot more severe. Tension type is more a band-like pain. And then the other ones we'll go through hopefully in the next few questions. So well done. And there is an aura, which is the visual disturbances prior to the headache. All right. For this question, we've got a 65-year-old male who has hypertension and AFib, and he comes to the ED with sudden onset weakness of the right arms and a right facial droop. On exam, he has significant weakness of the right arm and leg, mainly in the upper limbs. His lower limb strength is relatively preserved. He has sensory loss over the right lower face and the right body. His speech is fluent, but he struggles to find the right words. Which artery is most likely to be affected? Brilliant. Well done, everyone. I'll just wait a few more seconds for a few more answers to trickle in.
I've had some C's come through on my end as well.
Oh, fantastic. Good. So the answer here is 100% C. And I think what points you towards that, well, firstly, it's to localize which artery is affected. And given that it's mainly involving the upper limbs more than the lower limbs, we're thinking it's an MCA stroke. And the way to remember that is with that homunculus. And you remember the legs dangling off in the middle. And that tells you that if it's an ACA stroke, the legs are more likely to be affected. And because it's symptoms mainly on the right-hand side, we'd expect it to be the contralateral artery that's affected. So this patient most likely has an left MCA stroke, given their risk factors. So well done. Another question to do with strokes. A 50-year-old man presents to the ED with sudden onset dizziness, difficulty walking, and nausea. He reports a sensation that the room is spinning around him, along with vomiting. On exam, there's evidence of a horizontal nystagmus and leftward gaze deviation. He also has dysphagia, hoarseness, and decreased sensation over the right side of his face and left side of his body. So there's a lot of features here, but there's a few buzzwords in there, which I hope you're able to extract and help you to figure out which artery is affected. If not, that's totally fine, because if you know it, you know it. If you don't, that's something you'll learn after this question. All right. I've got a few responses in, and I've also got a few people already telling me what this patient most likely has, which is great. The answer here is D. We've actually got potentially a stroke of the pica artery. And what this is actually called is the lateral medullary syndrome, otherwise known as Wallenberg syndrome. There's a few things that help you to get there. There's like with all these stroke syndromes, yes, you can remember, you should go through the pathophys of which particular part of the brain is affected and therefore why they have symptoms. But eventually you'll get into the habit of pattern recognition and you'll see a specific constellation of symptoms and you'll know which artery is affected. So hopefully that gives you a bit of consolation if you weren't able to get there yourself. But things like vertigo, as well as dysphagia and hoarseness, those are very, very specific for a pica stroke rather than anything else. So if you see those things in a question, that tells you it's most likely to be lateral medullary syndrome. And again, with the pathophys, you can think about it as being specific nuclei in the brainstem that are affected, leading to those cranial nerve involvement. So well done for those of you who got it. In the similar vein, we've got another very typical syndrome of stroke. This time it's a 55-year-old man that presents with acute right-sided weakness and diplopia. He also has ptosis, along with a dilated pupil that doesn't constrict when exposed to the light. So think about potentially which cranial nerve is involved. His right eye is deviated outwards and down, and he has weakness of the right arm and leg. Additionally, there is contralateral hemiparesis affecting the left-hand side. So have a go at working through this one. Cool. Well done, everyone. So the answer here is actually C. You have a PCA stroke, and this is known as Weber's syndrome. The things that help you to get there is that this patient has likely an oculomotor nerve palsy. And because it's also presenting with the additional typical features of stroke, including contralateral hemiparesis, this is most likely to be a Weber syndrome. There's only a select few things that can lead to an oculomotor nerve palsy, things like Horner syndrome, or you can even have a PCA aneurysm that can press on the oculomotor nerve. But a PCA stroke specifically also leads to that denervation of the oculomotor nerve. So if you see that in the context of a stroke, it's more likely to be PCA than anything else. So well done for those of you who got that. And again, if you didn't know, that's totally fine. There's a huge number of stroke syndromes, dozens, but if you can remember the ones that are very, very commonly seen in exams, including Weber's and Wallenberg's, that'll set you up quite well in case you see those in your exams. All right, moving on. We've got the star of the show here. I'll let James do this question since he's self-referenced.
Why not? Why not? Awesome. Yeah, very good this one. See what you think. I'm getting some answers coming in. If you have one that you're sitting on, feel free to send it through. Awesome. All right, I'm getting a lot of A, which is good. So people saying A, what are you guys thinking? What do you think the underlying pathology is? Oh, never mind. The question is myasthenia gravis. Fair enough. So the acetylcholine receptor test is because the pathophys for myasthenia gravis is at that neuromuscular junction. So the problem is going to be at the acetylcholine receptor receptors. And so the best way to actually confirm the diagnosis, because it's currently a suspected diagnosis, is to actually do that objective test. As a side note, so I think really high yield in terms of like myasthenia gravis and eye complications, is to know that like progressive ptosis throughout the day is a big buzzword for myasthenia gravis. So ptosis in general can be lots of different things. It can be facial nerve palsies. It can be issues with the actual muscle. But if you get progressive ptosis, where it just gets worse, like in the morning it's fine, and then it gets worse and worse throughout the day, myasthenia gravis should be pretty high in your differentials. Yeah.
Great work. And great work to James for being the star ophthalmologist here who's diagnosed this patient. Moving on, we've got a 32-year-old male that presents to the ED following a MVA. He wasn't wearing a seatbelt and was ejected from the car. On arrival, he has a GCS of 13, but over the next hour, his consciousness rapidly deteriorates. And the head CT shows this. So I know a lot of people will probably have skipped the entire text and just gone to the imaging, which is totally fine because it's actually quite straightforward to tell from the image what this patient has. So again, type your answers in the chat. And I know that everyone has all sorts of ways of remembering how to differentiate the different types of hemorrhages on imaging. I'll give you my suggestion, but if you have your own, that's totally good as well. So yes, you're right. The answer here is epidural, and someone has already said the little mnemonic that I use is epidural has P in it, so it's like pi, and so the bleeding is sort of like pie-shaped. You can see that kind of lens-shaped or pie-shaped bleeding accumulation. I don't think we have a question on subdurals, so this probably won't spoil subdurals, but subdural has a B in it, so it's like a banana shaped. And so it's more likely to be banana shaped, moon shaped on imaging. So that's how you differentiate those ones. And you also have the clinical picture of a lucid phase. So you have them being all right for a little bit and then suddenly deteriorating. That's quite strongly pointing towards epidural as well. So well done. Okay, we've got a 6-year-old boy who's brought in to the pediatrician by his parents due to concerns about changes in behavior and coordination. Over the past few weeks, he has become increasingly irritable, clumsy, and has frequent falls. On examination, you see a wide-based gait, dysmetria, and intention tremor. So what do we think this patient most likely has based on the options? Great, well done. So most of you have gotten the answer here. The answer here is going to be B, medulloblastoma. And the reason why is because, first of all, this patient is presenting with more of he's got ataxia. He's essentially got symptoms that are pointing towards some sort of problem in the cerebellum. Could be multiple things, but the one thing that should be in your mind as a red flag is that this could be some sort of intracranial growth that is impinging on or affecting his cerebellar functions. And medulloblastoma is one of those tumors, brain tumors, that's quite common in children, and actually has a relatively good prognosis, but generally presents with more cerebellar symptoms, which you can remember with your mnemonics like Danish, that can be quite helpful. There's also a few other tumors here that might still be in the back of your mind if you have evidence of increased intracranial pressure that you would want to rule out, but all of these would require some form of imaging to rule them out first. So well done. Again, we've got a young person. We've got a 7-year-old child brought into the ED with high fevers, severe headache, and neck stiffness. We've seen this picture before. On exam, you note a petechial skin rash and photophobia. Laboratory tests show a markedly elevated white blood cell count with a left shift, and we also see papilledema. Actually, I feel like the answer here is going to be the same as the one that we did before. But just as a bit of a revision, if you want to write your answers in the chat, and potentially also write which option you would definitely want to avoid. Great, well done. So you would definitely avoid A. There are a few strict contraindications for lumbar puncture. If someone is severely sick, if they have evidence of raised intracranial pressure, like the picture of papilledema, if they have a very rapidly evolving petechial skin rash, those are all contraindications for lumbar puncture. So A is definitely off the list. And I just want to clarify with these, with the management. In this case, because we actually haven't confirmed properly that it is a Neisseria meningitis that's responsible for the meningitis, we cannot just give ceftriaxone. We actually have to give ceftriaxone with dexamethasone together, And until we have evidence with a gram stain or something that this is Neisseria meningitidis, we can remove the DEX. KEF and DEX are the empirical management regardless of what type of meningitis you have. Once you get evidence, then you can target it accordingly. Now, I also want to clarify that a few past exams have incorrectly said that the empirical management of meningitis is BenPen. That might be because in the past, that was what the guidelines had said. But now the guidelines, if you look at ETG, say ceftriaxone and dexamethasone. So if that's a source of a confusion for you, like it was for me, just know that it has changed. Okay. I think BenPen is specifically for if you have listeria meningitis, which is not very common, I don't think. All right, moving on to the next question. So we've got a 28-year-old overweight female who presents to the neurology clinic with complaints of persistent throbbing headaches, which are generally worse in the morning. It's associated with transient vision loss and a pulsatile tinnitus, and she has no significant medical history. Her physical exam is normal, except for bilateral papilledema on fundoscopy. So what is the most likely diagnosis? Great, I'm getting a few answers going in. All right, well done, everyone. So this might be a condition that a few of you have not heard of before, which is totally fine. The answer here is actually benign intracranial hypertension or idiopathic intracranial hypertension, if you've heard either of those. I know that this stem paints a very scary picture because you've got definite evidence of raised intracranial pressure. And you've also got these headaches that seem to be worse in the morning. And those are all red flags that make you think, like, does this person have a brain tumor or another space occupying lesion? And that is fair enough. But when it comes to exams, when you're looking for the specific buzzwords, in this case, you've actually got a lot more buzzwords that are going towards something a bit more benign, like an intracranial hypertension, which are things like transient vision loss. If it was persistent vision loss, that's concerning. It's transient in this case. We've got pulsatile tinnitus, which is not really common in a brain tumor. And unfortunately, this intracranial hypertension tends to be more common in overweight patients and also more common in female patients. So overall, with those buzzwords in mind, this is actually more likely to be B than a tumor. So for those of you who picked A, well done for thinking about the red flags, but the more likely situation is going to be B. And the treatment for this is actually quite straightforward. You don't need surgery or anything. You can be put on medications that will reduce that pressure. Well done. All right, another headache. Lots of headaches today. Hopefully you guys aren't having a headache. We've got a 35-year-old male who presents to the ED with severe unilateral excruciating headaches. He describes the headaches as stabbing and burning, localized behind his right eye and occurring daily at the same time for several weeks, followed by some pain-free periods. During the attacks, he gets nasal congestion, tearing of the right eye, and ptosis. He often paces around the room during the attacks due to the intensity of the pain. So again, a very scary picture to be reading, but I want you to think, what does this patient most likely have, and what is the most appropriate management? Amazing, well done. So this patient has a cluster headache, which we like the signs that point towards that are the very, very severe quality of the headaches. It's unilateral, it's behind the eye, and it's also associated with lacrimation and those sorts of features. That points towards a cluster headache. And really the mainstay of management if they present to the ED is that you want to start them on high flow, 100% oxygen, but also you want to add on subcutaneous sumatriptan. You may have heard of triptans in the context of migraines, but they're also really effective here. So there's a lot of high quality evidence for these interventions. Does anyone know I know I've written IV propranolol there, but in general, propranolol, where might that be used in the context of for headaches, primary headaches specifically? Yeah, brilliant. So it's prophylaxis for migraines. So yes, you would start in a migraine, you would start with a few pain medications, maybe triptans. But if they have recurrent episodes, then propranolol is very useful. Probably not IV though. So that's just for your interest. So yes, the answer here is B. Well done, everyone. You see a lot of GP themed questions here. It's because I'm on a GP rotation. So all I think is GP, GP, GP. So you're a GP sitting in your clinic. doing your paperwork after seeing a patient. Suddenly your receptionist comes into the room. This actually happened on one of my GP clinics. You have a receptionist comes into the room yelling that a man in the waiting room has collapsed on the ground and appears to be actively seizing. You start a timer and give the man some space. However, he continues to seize after 5 minutes. You call an ambulance as you think about what to do. So again, a very scary situation. So what is the most appropriate next step in managing this patient? So what is it called when a patient or someone has this, seizure that lasts for more than 5 minutes? And what medication are we going to start them on? Cool. Well done, everyone. So I'm seeing a lot of people also thinking about the setting that this patient is presenting in and which sort of interventions are more likely to be feasible. So that's a really good thing to be thinking about. And a lot of you have correctly pointed out that because it's a seizure lasting more than 5 minutes, it's classed as status epilepticus. So if you do notice a seizure, having a timer and seeing how much time has passed is really good because you're going to follow a set protocol. I'd encourage you to look at what the protocol for status epilepticus is up to, between 5 to 20 minutes. Obviously, you do want to be calling an ambulance, which they've done here. But at the 5 minute mark, before that, you wouldn't have done anything except for being there and kind of moving things out of the way so that they don't hit their head. But otherwise, after 5 minutes, you want to start them on a benzo. Ideally, as people have said, it would be nice to have IV access and give lorazepam. This is not in the hospital setting though, so it'd be very difficult to get an IV line into an actively seizing patient. So you can do something like intramuscular midazolam. It's very, very feasible to do something like that in the GP clinic. And that's actually what happened in the GP clinic that I was at. So it's very all right to do that. After some time, if that doesn't work, you can either redo the benzo, which some countries say is all right, or in Australia, they tend to move on to something else like Keppra, which is levetiracetam, or phenytoin. Either of those is all right as well. Well done. Okay, so you're in a neuro clinic this time with a 24-year-old female patient. They referred to you from the community after experiencing 2 episodes of, again, seizures in the last 3 weeks. She describes being conscious for both episodes and felt her right arm involuntarily spasm alongside uncontrollable lip smacking. Her arm usually feels weak for a few hours after the episode, and she's not on any contraceptive medications. So which medication is most likely to be prescribed for this patient in the long term? Okay. Well done, everyone. So the answer here, so I've actually listed the answer here as D, but now that I read this question, I realize that this is not painting a very convincing picture of a generalized seizure, because I've mentioned that it's mainly the right arm as well as some lip smacking. Technically speaking, if there's lip smacking, you're thinking it's more of a generalized seizure, because it's temporal lobe, plus you have a right arm, which is like frontal lobe. So it's not likely to be just focal, but I can see why that's a little bit confusing. So I do apologize for that. What I was going for here is that this patient has a generalized seizure. So for those of you who have put A because it's a focal seizure, you'd give carbamazepine. You are right in your own way. If we assume that it's a generalized seizure, then what would you give in that case? Can we go with that and see what we would pick? Yeah, also they wouldn't be, well, you can have complex generalized seizures where they can be conscious, but more likely to be unconscious. So that's why it's not a great question. I apologize. Yeah, so good. So you're all thinking really, really well. In this case, because you've got a young female patient who's not on contraceptives, you actually would try and avoid sodium valproate, even though that's usually the first line for a generalized seizure. So for generalized seizure, you tend to go with valproate, especially in a male. But in a young female patient, you want to avoid it because of its potential teratogenicity. And we don't know whether this patient could be pregnant or is planning a pregnancy. And we're thinking of putting them on this for the long term. So you actually don't want to give that, and you'd rather go with Keppra, which is D, levetiracetam. Ethosuximide is more for a absent seizure in children. So again, I really apologize for the poor question, but hopefully that makes sense. And if others see the recording, they'll know what I meant. Someone just asked what the difference between between general versus tonic-clonic versus focal are. So James, correct me if I'm wrong, but general and focal are the two major branches. Generalized meaning it's uncontrolled neurological activity throughout, and focal meaning in one specific area. And generally speaking, you can have complex focal seizures, or you can have simple focal seizures, depending on if they're conscious or not. Generalized seizures tend to be unconscious, but you can have rare cases where it's not. And again, it makes sense when you say focal, it's probably going to have focal signs. So you might have upper limb or lower limb. It might be specifically like a specific part of the body that it tends to be more affected. Tonic-clonic, that comes under generalized, doesn't it?
Yeah, so generalized can be motor or
generalized.
non-motor, and within motor there's tonic-clonic, tonic-clonic and atonic.
Yeah, absolutely. So tonic-clonic just means it's like flexing and then relaxing. You can have just tonic seizures, you can have just clonic seizures, you can have all sorts of different types of seizures. Tonic-clonic is the typical one you see in those American TV shows.
Yeah, and generalized, as far as I know, I might be wrong. Maybe there's other types of non-motor general onset seizures, but I believe it's mostly just absence seizures, which you're like space out, which is I'm not spoiling it, am I?
No, you're not. You're not.
Good.
I just told them ethosuximide is used for that one.
Yeah, perfect.
Yeah.
Yeah.
Cool.
Lip smacking is like a big, like they talk about it all the time. I don't know if it actually is like something that shows up all the time, but in Monash land and exams, yeah. Like you said, lip smacking, like bam.
Yeah. Lip smacking, tongue biting, those sorts of things are very like potential seizure. Cool. Well done, everyone. All right, we've got a 32-year-old male that presents to the clinic with progressive muscle weakness, and it's particularly in the proximal limb muscles. He reports that his symptoms worsen throughout the day and relieved with rest. Again, we've seen this picture before. You notice fatigability of his eyelid muscles when he sustains upward gaze for the extended period of time. EMG testing demonstrates a very similar picture with repetitive simulation, and we've got antibodies being positive. So we know what condition this is, hopefully by now. But the question here is a bit different. Given the likely diagnosis, which other investigation do you think is important to be done? Now, I encourage you to really think about this one, because there's an association between this condition that we know of already and another condition, I guess. Brilliant. Well done, everyone. So you're right. With this condition, first of all, what is the condition? Can I just get that out of the way first? What condition are we dealing with? Yes, myasthenia gravis. So we've got myasthenia gravis, which again makes sense because we've got their weakness getting worse with day and with repetition of movement. So that makes sense. But there's actually a 50% association. So people who have myasthenia gravis, 50% of them tend to also have a thymoma. And if they have a thymoma, you want to get rid of that or treat it as quickly as possible. And so most patients with a new diagnosis of myasthenia gravis will also get a chest CT done to rule out a thymoma. So hopefully that has helped you to figure out why that's the case. The other investigations will only be used if there is clinical suspicion of another complication. Thymoma is the big one for myasthenia gravis. Well done. Moving on. A 28-year-old presents to the clinic with recurrent episodes of visual disturbance, such as blurred vision and eye pain over the past year. She also reports intermittent numbness and tingling in her hands and occasional difficulty with coordination. On exam, you observe a relative afferent pupillary defect in her left eye, but fundoscopy is normal bilaterally. Again, we've seen this condition before, but the question is different. Which first-line investigation is most likely to confirm the diagnosis? First line. Good. I'm happy that none of you have fallen for the trap of a lumbar puncture because of our cerebrospinal fluid analysis. Because obviously the previous question where we saw a patient with MS, there was a cerebrospinal fluid analysis done. But actually, you don't need to do a lumbar puncture at all unless you are concerned, or basically there's diagnostic uncertainty. You're not sure if it's MS or something else. You might think it's a cancer in the spine or something that's leading to neurological deficits. For the most part, you just need a brain MRI with contrast. And there's a specific diagnostic criteria. I think it's called McDonald's or something, that is used in diagnosing MS, where you just need temporal and spatial evidence that there is changes in the brain that are typical of MS. And all you need for that is a brain MRI, not one. You will probably need multiple to demonstrate that temporal change. But the point of this question is that it's the first line one. It's not CT, for those of you who have answered that, because if you're trying to look at more neurological stuff, this is a great way to remember it. If you're looking for neurological stuff, you do MRI with contrast. If you're looking for blood-related stuff, you do CT without contrast. Write that down because it's super important. Brain stuff, MRI with contrast. Bleeding stuff, CT without contrast. So hopefully that helps. The answer here is B. Cool. We are missing the person who this question is talking about, but James, would you be happy to take this one about Janel?
Yeah, absolutely. Have a look at this one.
Also, after this question, we've got less than 10 questions to go for those of you who are asking, so not too long. You guys are doing very well.
All right, what are we thinking?
A few people have messaged me with E.
Okay. I've got a couple of E's and they're all quoting the Ottawa rules, which I'm very happy about, because that is correct. It is E, and it is because of the Ottawa rules. Okay. So remembering that we're looking for any pain in the malleolar zone. So she got marked tenderness over the left lateral malleolus, and we're looking for also either or bony tenderness along the tibia or the fibula, basically, or inability to weight bear. That was almost like more functional disability. We're not really sure in this situation whether the patient, sorry, she can weight bear there, so she can't weight bear there. So if the patient can't walk, you got to do something about it, right? So yeah, if we didn't have those flags, then we don't necessarily need an X-ray. Basically, it's not to say like whether there is a fracture or there isn't a fracture. It's more to say what's going to get us the most efficient care, basically. If we don't satisfy the Ottawa rules, the idea is that you have a low chance that your X-ray is going to change management, which is really what we care about when we're deciding whether or not to do any investigation. Don't order things that won't change things, like D-dimers.
Yes,
Awesome.
Always justify the investigations that you order. Great. Here is the next question. So you've got a 68-year-old male who attended your clinic, has actually passed away recently. In his last appointment, his caretaker described a gradual onset of tremors, bradykinesia, and rigidity over the past year. So first of all, what do you think this patient has? He also reported difficulty with initiating movement, stoop posture, and small cramped handwriting. On exam, there was rigidity and reduced arm swing while walking. This is presumably in the past appointments. So it turns out they're having an autopsy now. So which of the following is most likely to be found on autopsy of the patient's brain? And I apologize in advance because I hate pathology as much as the next med student. But this is really helpful, and it can actually be useful in explaining things to patients as well. No one's committing. Everyone's saying, is it C or D? And that's probably what I would do as well, because I've made this intentionally a little bit tricky. Everyone's on the right track. First of all, why is it not A or B? What is A and B talking about? Yeah, it's talking about Alzheimer's. So you have beta amyloid deposits, which are usually extracellular, and then neurofibrillary tangles that are intracellular. That's quite typical of Alzheimer's. C and D could be to do with this patient, which is, as some people have pointed out, this patient has Parkinson's. So we've got a lot of those features there, including the rigidity, bradykinesia, tremors. And yes, you do have depigmentation in the substantia nigra, but it's not in the pars reticulata, it's in the pars compacta. So that's the only thing that's wrong with C. And the depigmentation, for those who might, angry faces in the chat, I can see that. The reason why it's depigmentation is because you have loss of the dopaminergic neurons. Again, that's why E is wrong. E is saying adrenergic, which is wrong. You actually have the alpha synuclein aggregates. Does anyone know what the name of those aggregates is? Where there's like another name for those? Yeah, they're called Lewy bodies. So Lewy body is what you get as a buildup in Parkinson's. So that's what D is talking about. I see a lot of people are probably not very satisfied with this question. I apologize, guys. But hopefully that's clarified the pathology surrounding Parkinson's. And we're going to swiftly move past that because no one likes a pathology question. So a 55-year-old male presents to the ED with sudden onset severe pain and swelling at the base of his right big toe. This is very high yield. He has had 2 episodes of pain like this and had a synovial fluid analysis with needle-shaped negatively birefringent crystals. He usually takes naproxen for the pain, but this does not work for him anymore. The joint is red, warm, and very tender. Blood tests reveal a serum uric acid level that is below the normal range. So what is the most appropriate next step in managing this patient? First of all, what do you think the patient has? And how would we go about making them better in this acute state of pain? Good. So most people are saying that we think he has gout, which is great. So I'm glad no one has picked A. Can someone tell me why does this person have a low serum uric acid level? Doesn't gout have to do with lots of uric acid, and that's why you get those gouty crystals forming? Yeah, perfect. Because most of those crystals are precipitated out into the joint. So paradoxically, you get actually a low serum level of uric acid. So you don't need to remeasure it. Plus, you have the clinical picture. You technically didn't actually need to do a synovial fluid analysis. The clinical picture is itself enough to diagnose someone with gout. So now the question is, what do we do? So we've got a few options here, except for D. The other options can actually be used in the management of gout. So colchicine, allopurinol, these sort of xanthine oxidase inhibitors, as well as intra-articular glucocorticoids. I'll get to that in just a second. But the answer here is actually going to be what? B or C? Which one is used in the acute management? Which one is used in the chronic management? Yeah, exactly. So allopurinol is used later. It's used in the chronic management. If you give someone with acute gout allopurinol, you'll actually make their gout worse. It'll actually worsen the gout. So they would not appreciate that very much. You give them colchicine. Well, you give them NSAIDs first, like naproxen. That hasn't worked. Then you give them colchicine, and that hopefully will work. And then you start them on long-term uric acid medications like allopurinol. There's also a few other ones like febuxostat or something. Allopurinol is the more common one. So well done. The answer here is B. You wouldn't go to a glucocorticoid injection because that has very little evidence going for it. If you actually look at the ETG guidelines, glucocorticoids, maybe they're mentioned, but they're mentioned very, very low because that's not a very common thing to inject. It actually also increases the chance that they can get septic arthritis and that sort of thing in the joint, which is already in an inflammatory process. So there's actually new evidence. We learned this in GP. You don't give glucocorticoid injections anymore for these sorts of patients. But good question. You'd think it'd be helpful, but not. Okay. A 26-year-old male presents with a history of chronic lower back pain and stiffness that has been worsening over the past several years. He reports that these symptoms are worst in the morning and improve with physical activity. On exam, you note a limited lumbar spine mobility and decreased chest expansion. He also has tenderness over the entheses of his heels, so where the muscle attaches to the bone. What is the most likely diagnosis? Yeah, great. Don't really need to explain this one too much. The answer here is ankylosing spondylitis. We've got a relatively young male patient, which is the more common demographic you'll see this in, as opposed to the other types of arthritis, which is generally more common in older patients. And it's affecting the lower back more so than like the hands and small joints, which is quite typical of ankylosing spondylitis. And the way to diagnose this, well, I guess, can someone tell me, well, how do you diagnose this? Do you need imaging? Do you do blood tests? What is the gold standard? Yeah, exactly. So you would do a actually no, so you wouldn't do a HLA-B27, although there's a very common association with it. That's not the gold standard diagnosis. The most common sort of first line thing you would do is that you would just do imaging. You would do X-ray of the lumbar spine. That will show sacroiliitis. HLA-B27 is not commonly done anymore. You don't need it to make a diagnosis of ankylosing spondylitis. You can do it if you have high clinical suspicion and imaging is not contributory, then sure. And someone mentioned bamboo spine. Although you see that in ankylosing spondylitis, it's very late stage. So you're less likely to see that as the sort of first presentation. You would do an X-ray, you wouldn't do an MRI, because you're more focusing on the bones than the soft tissue. Cool, well done. All right. Again, a very detestable question on antibodies. You got a 45-year-old female who presents worried after difficulty swallowing solid foods for the past year. She also mentions that the tips of her fingers often turn blue in the cold, which we discussed before is Raynaud's phenomenon. And her husband tells her that her skin looks tight and shinier than usual. On exam, you observe thickening of the skin in her fingers and hands with telangiectasia on her face. And so, because somehow you figured out that this is constellation of symptoms means one condition, you decide to order some specific autoantibodies for that condition. And so my question to you is, which antibodies are most likely to be seen given that disease? Does anyone know the nice like mnemonic that you can use for this condition? Something syndrome. Yeah, it's CREST syndrome. So if you know what each of those letters stand for, then it's really helpful to know what condition we're dealing with, because this patient is presenting with pretty much all or most of them, including like you can see the esophageal dysmotility with the swallowing. That's also part of it. So the answer here is actually D, because we have a patient who has CREST syndrome, which is a type of limited sclerosis, limited systemic sclerosis. There's also a diffuse systemic sclerosis, which is a slightly different entity, but you're most likely to see the limited version. It's much more common and it presents with the typical features. So there's two autoantibodies here that are seen in systemic sclerosis. That's A and D, but the anti-centromere one is more likely to be seen in the limited version, whereas the anti-SCLE70 is more likely to be seen in the diffuse version. The answer here is going to be D. It's also a good idea to know what the other antibodies are for. So what is anti-dsDNA and what is anti-CCP and anti-mitochondrial antibody useful for in diagnosing. Awesome. Let's do the next one. This is not mine. This might be, James, do you want to take this one? It's Deepak's
Absolutely.
question. I think it's Deepak.
Let's do it. All right. We have a patient who we are suspecting of osteoporosis, and the question is, what are their labs going to come back as?
Just to let you know, James, I've got a few D's and E's in my messages.
No worries. All right. I'll give you guys a moment longer to try. Cool. All right. So I didn't write this question, but the intended answer is actually A. Um, so I guess the thing to take home is that osteoporosis is very, very capable of having normal results. All right. So there's no reason that you necessarily need to have elevated labs. When we do have changes in the blood, Janum can correct me if I'm wrong, but I think the two big flags that you look for are parathyroid up, vitamin D low, and sometimes, well, vitamin D low will be low in certain cases, depending on what the etiology, and ALT up potentially, with stuff like osteomalacia. So there can be lots of different things, but the idea is like that might be more indicative of the etiology of the disease than not. So in this patient, I don't think we really have any signs that they would indicate they'll need to have a certain abnormal blood result. If we have a more specific pathophysiology, then it makes sense for us we can look for that on the bloods.
Absolutely. Yes, you're right. As always, James, with regards to these bone profiles, it's really good to just know the general pattern of what you might see with calcium phosphate, ALP, and PTH, which are all sort of related to the hormones responsible for bone, the bone cycle. With regards to osteoporosis, though, you don't really have any problems intrinsically with the bone itself. So you actually will have a normal values for everything across the board. One thing that's really interesting is you can, as option C notes, is you can have an isolated increase in ALP. As James mentioned, that's very, very like bone specific. And like it's not like just liver stuff, it's also bone stuff. If it's just ALP and all the other liver stuff is normal, you might suspect things like osteomalacia that James mentioned. Well done. Okay, so you've got a 47-year-old man who last attended your clinic with an unexplained tiredness and stiffness around the shoulder joints. He presents again today, but this time with the same complaints and also a mild headache. He describes it as a throbbing, dull ache over the left forehead and mentions being unable to eat because of some jaw pain. On questioning, he does not mention any vision changes, although he remembers having a mild infection 2 weeks ago. What is the most appropriate next step in managing this patient? So in a very scary, if you know what condition this is talking about, it's a very scary presentation for you. All right. So most of you have correctly identified that this patient has GCA, giant cell arteritis. Specifically, in this case, we're thinking it's there's a chance that it could be temporal arteritis because GCA can affect lots of different arteries. But absolutely right. And we also think that this patient probably has polymyalgia rheumatica from before. And we know that there's an association between the two. Not every patient with polymyalgia rheumatica will get a GCA, but most patients with GCA do have polymyalgia rheumatica. So just remember that and keep that in the back of your mind. So one thing that we're really worried about is vision. In this case, there's sparing of vision. So we're not quite at the stage yet where we would be really worried, but we're worried enough that we want to treat this patient with something. And the mainstay of GCA as well as polymyalgia rheumatica management is steroids, and that too high dose steroids. Now the question is, do we give it IV at this point, or do we give it as an oral preparation? And actually, if you look at ETG, if a patient does not have any vision changes, this mild eye infection is just there as a bit of a trick. It's nothing to do with what the patient is coming in with. People have eye infections all the time, so that's not a concern. If there were vision changes, though, we would straight away admit them and start them on high dose IV steroids. But because they have vision sparing, you can actually get away with just oral steroids and then reassess them after they've been on the course. And this actually happens all the time. I didn't realize how common GCA and PMR were until I was on my GP rotation. And in the last 5 weeks, I've seen more than a dozen. It's actually really common. But most of the time, there's no complications of vision loss. And so they'll just be given high dose oral steroids. And there's a specific formulation that you put them on, and then you down regulate the steroid once they get better. But you definitely want to start them on something, just not IV at this stage. Cool. Well done. All right. I believe this is the second last question, so we're almost there. A 65-year-old female patient with long-standing history of knee pain presents to your clinic. She describes her pain as worse with activity, relieved with rest. On exam, you note bony enlargement of the PIP joints of both hands and hard bony nodules at the DIP joints and associated stiffness in both joints. The knee exam reveals crepitus, limited range of motion, and tenderness over the joint line. So given the most likely diagnosis, what do we think the imaging is going to show? I know I've put a lot of words here, but I could have summarized this, some of these findings with the more common names you use. So just as a bit of a quick fire, what are the bony enlargements of the PIP joints called? Yes, Bouchard's nodes. And what about the DIP joints? Evidence. Well done. And you can remember that with B comes before H. So proximal ones are going to be the Bouchards. Good. And also, if you look at the description as with the pain getting worse with activity, relieved with rest, that paints more of a mechanical picture of arthritis. Whereas if you have a inflammatory picture, generally the pain is not relieved with rest. It actually is better with more movement because you're moving around the joint, reducing the inflammation. So in this case, what condition do we think this patient has? Given Bouchard's, Heberdin's, all that sort of stuff. Yeah, we think they have osteoarthritis. So a lot of you have already put your answers in. We're going to see that osteophyte formation. And you know that there's that like a few mnemonics going around for the 4 major findings on X-ray of a joint for osteoarthritis, and osteophyte formation is definitely one of them, which is good. Actually, hold on. Yeah, they do. Sorry. Joint space widening is not the answer. Joint space loss would be a typical feature of OA. Can you explain what option C is? You've read my mind because I wanted to ask you what option C is talking about. What is pencil and cup deformity suggestive of? Yeah, it's actually quite suggestive of psoriatic arthritis, especially in the hands. What you will see is it's better with a picture. It's never really looked like pencil in a cup for me, but that's the way it's described. Essentially, it'll look like the bottom bit, the bottom part of the joint looks like a cup because it's widened and it has like a U shape. And then the top bit looks like it's inserting into that cup shape. So it's a pencil in a cup deformity. And you see that in patients with psoriatic arthritis. Chondrocalcinosis is something I believe you see in pseudo gout, and soft tissue swelling is very non-specific. So that's wrong. Well done. So now we're on to the last question. A 45-year-old male patient with a history of IV drug use presents to the ED with an acutely swollen and painful right knee. He reports a fever of 38.6 and an inability to bear weight on the affected joint. On exam, the knee is warm, red, and tender on palpation. Aspiration of the joint reveals purulent fluid, and analysis of the synovial fluid shows elevated white blood cells with a predominance of neutrophils. And further analysis is performed. So what are we most likely to see on that further analysis of the synovial fluid? Yes, very, very good. So we've got a patient who most likely has septic arthritis. Again, if you see a red, swollen, tender joint, you're thinking it's either septic arthritis or potentially gout or maybe something else. But septic arthritis is the main one you want to rule out. That's why you're doing the synovial fluid analysis. And in this case, because we've got elevated white blood cells with the predominance of neutrophils, it's a bacterial cause, which is very common. Septic arthritis is most commonly caused by Staph aureus, and we've got a few risk factors like IV drug use put in there as well. And this is kind of going back towards a bit of microbiology. So Staph aureus is most likely to be a gram-positive cocci in clusters. And the gram-negative diplococci, I just encourage you to know essentially what gram stains some of these bacteria are and what shape they take. Because I remember in a few exams, especially as well as ours, they tend not to give you just the name of the bacteria. They might sometimes just put in the characteristics of the bacteria, and you should know what they're talking about. All right, I think that's all the questions that we have for you today. So well done, everyone, on getting through a lot of those questions, some very tough ones in there, but you all did a really, really good job. Does anyone have any questions at all for us before we end today's session? I just gotta actually we might stop the recording.
I said that I was muted.
Yeah.
So
Um,
goodbye to all the people online.